Good evening, everyone. I'm Dr. Raman Sharma. So I welcome you all in this second innings of our academic lecture series that we are conducting under the aegis of Haryana AOI. So in this year, this is the third session. And today we have a case presentation by a candidate from BPS Kanpur. And the case she is going to present is a supraglottic carcinoma. So before she starts, I would like to invite our experts for today's session. So we have an external experts and internal expert from BPS Kanpur itself. So first, I would like to invite Dr. Ishwar Singh sir. Sir is currently working as Director Professor at Maulana Azad Medical College, and he has also served as director at two big institutions in Delhi at Indira Gandhi Hospital and Baba Sahib Ambedkar. And now he has again come back to us and joined MAMC and working as director professor. And sir has special interest in head and neck oncology. So, and sir is also my teacher. I have learned a lot from him. So thank you very much, sir, for sparing your time. Our second external expert is Dr. Indu Shukla ma'am. Indu ma'am is from currently working as assistant professor at RML Hospital, and she has served as assistant professor from 2019 onwards. She was working at Kalyan Super Specialty Hospital Cancer Institute at Lucknow, and she has performed 350 head and neck surgeries with flap reconstruction, and currently working at RML Hospital as assistant professor. And she has a special interest in head and neck oncology. So welcome, ma'am. Thank you very much for sparing your time. And our internal expert is Dr. Uma Garg, ma'am. So the resident also is from BPS Kanpur. So welcome, ma'am. Thank you very much, ma'am, for allowing us to conduct this session with your candidate. The participant is from BPS Kanpur. So Anu, now you can. So now, Anu, you can take the permission of your experts, and you can start sharing your screen. And then, with the permission of experts, you can start your case presentation. So I request all the experts to please ask as many questions as possible, so that residents gain maximum from this. Thank you.
Good afternoon, everyone. Good evening, everyone.
Hello, Ishwar.
क्या लूमा? Good evening, Dr. Umagar.
Good evening, Ganga.
Dr. Ravi, good evening. I think Dr. Ravi has not.
So I have muted all the participants. So Dr. Anu, now you can unmute yourself and you can start the case presentation by taking permission from the experts.
Good evening, everyone. So can I start my presentation?
I think you can.
Dr. Ishwar sir, give the permission.
Start her presentation, I think.
Yes, Anu, you can start.
Good evening, everyone. I'm presenting a case. Patient name Sunil, 38-year male, resident of Kharkhoda, Sonipat, studied up till 7th standard, tailor by occupation, Hindu by religion, married, and belonging to lower socioeconomic status. Presented with chief complaints of change in voice for 2 months, difficulty in swallowing for 15 days, difficulty in breathing and noisy breathing for 15 days. History of presenting illness. Patient was apparently asymptomatic 2 months back when he developed change in voice, which was insidious in onset, gradually progressive, hoarse in nature, and there was no diurnal variation. Patient also complains of difficulty in swallowing for 15 days, which was insidious in onset, gradually progressive. Initially, it was for solid. Now the patient is having difficulty in taking semi-solids and liquids. There are no aggravating and relieving factors. It is not associated with pain and cough during swallowing. Patient also complains of difficulty in breathing for 15 days, which is insidious in onset, gradually progressive. Initially, the patient was having difficulty in climbing stairs and doing strenuous exercise, but now the patient is having difficulty in taking few steps, and he has to take rest frequently after after walking few steps. It is associated with noisy breathing, which is the noisy breathing is during the inspiration. There is no relieving factor associated with it. There is a history of weight loss. Patient gives history of loosening of clothes. There is no history of trauma to neck, no history of vocal abuse, no history of ear pain, no history of evening rise of temperature or night sweats, no history of ingestion of acid or alkaline substances. Treatment history: patient is consulting BPS GMC for 1 week, but is poorly compliant for treatment. Past history: there is no similar complaints in past. No history of diabetes, mellitus, hypertension, asthma, tuberculosis, jaundice, and seizure. There is no history of any surgery in past. Family history: there is no history of similar illness in family. No history of diabetes, mellitus, hypertension, asthma, tuberculosis, jaundice, and seizure in the family. Personal history: patient is vegetarian by diet. Appetite is normal, but the intake has reduced. Sleep is disturbed. There is history of BD smoking for 14 years, 1 bundle per day, and his patient is currently smoking. There is no history of alcohol consumption. There is history of alcohol consumption for 14 years. No history of tobacco chewing or hookah smoking. Bowel and bladder habits are normal. General physical examination: patient is conscious, cooperative, and well oriented to time, place, and person. Patient
Before completing the history,
is
some more relevant points.
sir.
Dr. Ishwar sir, any more relevant point in the history? Dr. Uma, any history of cough?
Sir, no, there was no history of cough, sir.
One thing I would also like to ask, like you mentioned while talking about noisy breathing, that it was more on inspiration. So, did the patient tell you that this was more on inspiration, or in history you're writing what patient is telling you?
Ma'am, actually, we observed that it was not told by the patient.
So, is that a part of your examination?
Yes, ma'am.
Okay.
Then
Ishwar
continue.
sir, you need to unmute yourself. Ishwar sir, please unmute yourself.
Dr. Ishwar?
I think must be in
Yes, sir.
his phone.
Now you are unmuted, sir.
That is a inspiratory stridor is a part of examination, not a history.
Yes, sir.
Noisy breathing, difficulty in going upstairs, that is a part of history. That is, he is not able to carry out day-to-day routine activity.
Yes, sir.
But the symptom started, you said hoarseness. Hoarseness is the first symptom of which side? Larynx is divided into how many parts?
So there is supraglottis, glottis, and subglottis. And sir,
Hoarseness as a first sign is a part of which part of the larynx?
sir, if glottis is involved, then the first symptom will be hoarseness of voice.
That is what your case says or history says.
Yes, sir.
And if supraglottis is involved or subglottis is involved, then what is the first symptom with which the patient presents?
Ma'am, in supraglottis, the patient will have difficulty in swallowing, and if the subglottis is involved, patient will have dyspnea first as a primary symptom.
In your history, all these symptoms are there. He has an inspiratory stridor, as you mentioned. He has a
Yes, sir.
dyspnea. All of the larynx is involved.
Sir, yes, maybe the growth started in the glottis and it went, it involved the supraglottis.
Also, you had asked about diurnal variation when you were speaking about change in voice. What is the significance of this history?
Ma'am, diurnal variation is seen in if the patient is of Rinke's edema, patient will have hoarse voice in the morning, and with as the time passes by, his voice will improve.
And
Whereas if the patient,
voice deteriorates in the evening,
sir,
voice deteriorates in the evening, diurnal variation, it is better in the morning, but goes down in by the time patient sleep or evening.
sir, the edema with time, basically it subsides.
No, sir is asking what if the voice is becoming worse in the evening? What could be the likely cause?
Ma'am, it can be seen in myasthenia gravis or in dystonia.
इडिमा तो परसिस्ट करेगा, वो थोड़ी ना इतना एकदम से कम ज्यादा होता है. Ravi's question is, there is no diurnal variation. Do we have such a diurnal variation in Rinke's edema?
In morning, the voice is more hoarse in Rinke's edema in comparison to.
क्या वो ग्रेविटी से
Chronic laryngitis.
चलो. Go ahead, examine
Yes, sir.
the examination finding.
Yes, sir. Journal physical examination. Patient is conscious, cooperative, and well oriented to time, place, and person. Poorly built and poorly nourished. Stridor is present. It is inspiratory type. The pulse rate is 115 per minute. Blood pressure is 120 by 90 mm of mercury. The SpO2 is 94% at room air. Pallor, icterus, cyanosis, clubbing, and edema is absent. Generalized lymphadenopathy is absent, but cervical lymphadenopathy is present. Local examination. Oral cavity, mouth opening is adequate. Lips, angle of mouth, teeth, gingiva, gingivo-buccal sulcus, gingivo-labial sulcus, buccal mucosa, hard palate, anterior 2/3 of tongue, floor of mouth, and retromolar tiburon is normal. Oropharyngeal examination, bilateral anterior pillar, tonsillar fossa, posterior pillar, posterior 1/3 of tongue, soft palate, uvula, posterior pharyngeal wall, and tonsillar lingual sulcus is normal. Based on base of tongue on palpation, there was no induration. The tongue movements are normal. On indirect laryngoscopy, a proliferative growth was seen in the right aryepiglottic fold, right arytenoid, right false vocal cord, and right true vocal cord. Pooling of secretion was present in right pyriform sinus, and the left pyriform sinus was normal. The base of tongue, medial and lateral grossoepiglottic fold, ventricula and epiglottis were normal. Left aryepiglottic fold, left arytenoid, false vocal cord, and true vocal cords were normal. Left vocal cord was mobile with phonation and respiration. Neck examination. The trachea was central. Cervical lymphadenopathy was present. On the right side, level 1.
Extension, since the patient has a stridor and he has distress, he can't walk around. The growth is just limited to the supraglottis. Could you see the true vocal cord on that side?
So true vocal cord on the right side was not seen. It was seen on the left side.
Why that cord was not seen on left side?
Sorry, sir.
Why the cord was not visible?
Sir, on the right side, it was not visible because the growth was over it. Maybe the growth.
Overhang of the growth.
Overhang, maybe. Yes, sir.
Any subglottic extension, because you mentioned the patient has stridor and he had though stridor can be explained, but what about that distress while on sitting and doing routine activity? Any subglottic extension?
Sir, it was not seen on endoscopy, sir. And
You have a endoscopic picture? That is your hand drawn.
yes, sir.
We would
Sir, I
like
have
an endoscopic recording.
sir, I have a recording. I'll show.
There is hardly any glottic chink here, madam. The diagram which you are showing and it is not correlating with the diagram and the video. There is hardly only a posteriorly small hole is visible. You can play it again, that final finding.
Yes.
Play again your
So that everybody can notice it again. यहाँ फ्रीज कर लो बस यहाँ पे। तुम्हारा रिकॉर्डिंग अच्छा नहीं है।
Camera quality is not good.
हाँ।
Yeah.
Small hole posteriorly, just anterior to the retinoid, you can see a small V kind of blackish shadow through which the patient may be breathing. Rest of the whole of the laryngeal glottis is totally blocked.
Looks like a bilateral growth, Dr. Ishwar.
Yes.
So growth was not exactly on the other side. It is unilateral only. But
But this appearance of the other side, it doesn't say it's normal. Dr. Uma?
Vocal cord तो दिख ही नहीं रही।
No.
vocal cord लेफ्ट साइड में दिख रही है, राइट में जो है इन्होंने ड्रॉ करी हुई है, लेकिन इसमें नहीं।
इसमें तो क्या दिख रहा है, वीडियो में क्या दिख रहा है? कोई ग्लोटिस नहीं हो तो ग्रोथ ही ग्रोथ दिख रही है, पूरा ल्यूमेन तो है नहीं, ग्लोटिस तो कहाँ है?
वीडियो दोबारा चलाओ जरा, 1 मिनट स्लो करके।
देखो ये एपिग्लोटिस आई, ये एपिग्लोटिक फोल्ड आया, arytenoid are swollen, only small opening is seen posteriorly.
Sir, it looks like the part of growth over the right vocal cord is obscuring the view of anterior part of the left vocal cord. And there's a bulk that is obscuring the piriform fossa as well, which she did not show in her diagram.
Yes.
It is hemilarynx growth, I think so.
Yes, it's right hemilaryngeal.
It is overhanging, so that is why it is appear.
तुम्हारा कैमरा अच्छा नहीं है।
अपने आप ही बनाइए, अब कैमरा देखना पड़ेगा।
डॉक्टर उमा का कैमरा नहीं है, हरियाणा गवर्नमेंट का कैमरा है।
ये इन्होंने बनाई है, देखना पड़ेगा आगे।
नहीं तो सुपरवाइज तो
एक्चुअली नहीं,
पहले
सुनो, मोबाइल में थोड़ा सा बेटर दिख रहा था, इस वाले स्क्रीन पे तो बिल्कुल ही अच्छी नहीं आ रही है वीडियो।
चलो एनीवे गो अहेड।
Neck examination.
Neck examination, trachea is central, cervical lymphadenopathy is present. On right side, right level 1B, lymph node 1 into 1 centimeter, non-tender and hard and mobile. Right level 2, 3 into 1 centimeter, non-tender, firm and mobile. Right level 5A, 2.5 into 1.5 centimeter lymph node, which was non-tender, hard and mobile. Right level 5B, 1 into 1 centimeter, non-tender, firm and mobile. Laryngeal crepitus was absent and the splaying of thyroid cartilage was present. Nose examination.
Level 1B?
Sir?
Level 1B.
Sir, level 1B is a submandibular group of lymph node.
ओरल कैविटी में या lateral border of tongue पे कोई अल्सर कोई है क्या वहां पे कुछ finding?
No, sir.
Then by this growth, level 1B is not explainable. Is it hard formed just like your secondary metastatic है क्या?
Sir, level 1B was
1B, could there be any other causes for level 1B?
Most commonly dentogenic can be there if dental hygiene is not proper.
Yes. There is some ulcer or lesion in the oral cavity that will lead to 1B enlargement.
But that should not be hard.
Yes.
He has mentioned hard.
He's mentioned
Yeah.
hard.
It should not be hard. Tell us about
Laryngeal crepitus absent. How do you explain this?
Sir, when we move the laryngeal framework, the cricoid cartilage over the prevertebral fascia, there is a sound, but there was no laryngeal crepitus elicited in this patient.
Sir is asking, how do you explain laryngeal crepitus in this?
Why the laryngeal crepitus is absent in this when the growth is endolaryngeal?
Sir, it may have extended to the post-cricoid region, sir.
And the
Pariform sinus is normal.
dysphagia.
You have shown us the video. It is not extending.
Playing of the thyroid cartilage. Is there any tenderness there when you palpated the larynx?
Sir, tenderness was not present, sir.
What is the significance of eliciting tenderness? That is one point that was missed in your neck examination, mentioning in your neck examination.
Ma'am, if there is any, in this case, it will.
Yes.
Ma'am, metastatic
Yes, Ravi, gritty sensation which you feel, it is felt, not heard. I agree to you.
Gritty sensation or grating sensation? ठीक है, gritty और grating.
वही जब रब करता है तो वो फील होता है उसके अंदर.
Sir, it is actually grating sensation which is felt by the examiner. It is not a sound which is to be heard.
Not heard, it is felt.
It is
You
felt.
are right, right.
It is a grating sensation when you move the larynx over the vertebra, you feel it, right?
And this is because what is the cause of this gritty sensation, Dr. Sam?
Sir, if the growth will go into the post-cricoid area, the gritty sensation will not be present.
Normally,
If it is
phenomenon that's what I'm asking you.
Sir, can you repeat, sir?
What is the reason for this gritty sensation?
Sir, when the cricoid cartilage, it moves over the prevertebral fascia, so we get this gritty sensation.
So cricoid cartilage is signet type. It is complete and the posterior lamina is wider that rubs on the vertebra or the prevertebral fascia and that gives the sensation and not the thyroid cartilage. So it is
thyroid is open posteriorly, so it is the cricoid cartilage that gives the sensation. And why it is absent in this case? What are the other causes of absence of laryngeal crepitus? What are the causes of loss of laryngeal crepitus?
Post-cricoidal growth and.
अरे जर्नल बता दो ना, और भी तो causes होते हैं. Retropharyngeal abscess, any mass which is there.
So anything between the cricoid cartilage and prevertebral space, fascia or vertebra, any mass that will cause loss of.
And here you can explain that the growth may be extending or it may be going posteriorly into the postcricoid area. But then the symptom should have been dysphagia rather than hoarseness of voice.
Yes.
And then it becomes postcricoid carcinoma, that is more common in female, not in males, but extension of the growth might lead to that presentation.
So how do you say about splaying of thyroid cartilage? क्या बोला आपने ये?
Ma'am, the angle between the two ala of the thyroid cartilage, it increases. And when there is involvement of the paraglottic space is involved, then there will be splaying of the thyroid cartilage.
And what is the prognostic significance of this finding on your patient? If there's a splaying of thyroid cartilage.
Ma'am, there will be upstaging of the tumor when the thyroid cartilage is involved. So,
is the thyroid cartilage tender on palpation?
No, sir, it was not tender on palpation.
Dr. Ishwar, you agree with the lymphatic spread from 1B to 2, then 5A and P? Level 3 is not involved?
That is skip metastasis.
Explanation is good. Okay. But usually skip metastases are seen in post-RT cases, not.
That is seen on histopathology when you send all the samples are sent and then you find that one of the level is without any metastasis. That is the way you
okay.
Skip metastasis. But
just to discuss the lymphatic drainage from supraglottis, it will go to somewhere else, glottis somewhere else, subglottis somewhere else.
Yes.
And pariformis.
Can you tell us, Anu, can you tell us the lymphatic drainage?
Yes, ma'am. So from supraglottis, it mainly goes to level 2, 3, and level 4. In glottis, when the lymphatic involvement is not primarily seen in the later stages, it can be seen at level 6, and in subglottis, it first goes to level 6 and then to level 4. Sir.
And from glottis, it goes to which name of the lymph node? What is the name of that node?
So level 6 is, sir, Delphian node, sir.
And in New Scotland, what is the other name given?
Pre-tracheal and paralaryngeal.
Why there is a difference in the lymphatic drainage?
Sir, there is a sir, developmentally, sir, the glottis developed from fusion of the two cartilages in the midline, whereas
अरे कौन सी ब्रैंकियल आर्च से डेवलप होता है सुप्राग्लॉटिस एम्ब्रियोलॉजिकली? Supraglottis develops from which bronchial arch during embryology?
The first and second bronchial.
No, you are not right. Third, fourth, and glottis and subglottis.
So glottis develop from 6.
6. Subglottis and glottis, they develop 6. So embryologically they are different. So the lymphatic drainage is also separate. The supraglottis drains into level 2, 3, 4, and 6. And pretracheal, that is delphin node. And subglottis drains into?
The subglottis also, it first drain into level 6 and level 4, sir.
And supraglottis drains both sides?
Yes, sir.
Even subglottis can drain to.
Next.
The nose examination and ear examination were normal. Differential diagnosis can be a growth supraglottis, probably a transglottic growth, with a clinical staging of T4A, N2B, and MX.
So you mentioned in your history, change in voice was the first symptom that the patient presented with. And your differential diagnosis.
Chronic smoker, first symptom as hoarseness of voice.
It will be glottis, growth glottis, which is going.
What is the symptomatology of supraglottis patient? Rawness, difficulty in swallowing, irritation, repeated clearing of throat, difficulty in swallowing. Non-specific are the symptoms. Here the symptom was very specific, hoarseness of voice. And your video also supports.
Yes.
So do you want to change your probable?
Yeah, yes, ma'am. It is growth glottis, which is probably a transglottic growth, which is extending to the supraglottis.
When you call growth as transglottis?
Sir, because it has crossed the ventricle and then it has reached the supraglottis.
When it crosses the ventricle, so from glottis is started and came upward.
Yes, sir.
Enumerate the subtypes of supraglottis.
Yes, ma'am. It is a suprahyoid and intrahyoid epiglottis, the aryepiglottic fold, arytenoid, and the false vocal cord. Sorry, it is N2B, ma'am. It is unilateral multiple lymph nodes, which was none was more than, it was more than 3 centimeter, but none was more than 6 centimeter, and there was no extranodal extension seen.
Why do call it 4?
Sir, 4A, sir, it has involved the thyroid cartilage.
Said it is non-tender. On palpation, it is non-tender.
Yes, sir.
स्प्लेइंग से क्या मतलब है? वो तो जैसे एंगल होता है ना, वो स्प्ले होता है, जैसे ट्रॉमा के बाद से एक्सीडेंट हो गया, कोई डंडा लग गया, या बस में बैठा हुआ बस का जो हैंडल होता है वो लग गया, या ड्राइविंग में गर्दन जाके लग गई, तो योर एंगल बिकम्स वाइड, तो स्प्ले हो जाती है. तो फिर तो T4 कैसे हुआ फिर? Has it come out of the subcutaneous, or you can feel the growth? Has it involved the prelaryngeal muscles?
No, sir.
Then? N2?
Sir, N2B.
What is the size?
See.
Sir, the size of the lymph node was one of the lymph node was more than 3 centimeter, but none was more than 6 centimeters. So that is why it is N2B, and it is ipsilateral multiple nodes are involved.
So now, how will you manage? What investigation would you like to do?
So first we'll proceed with the normal hemograms, the complete blood count, and then the radiological investigations, which we'll go for is the contrast enhanced computer tomography of neck and the thorax, from skull base to thorax.
So show the finding.
Sir, scan film is not. Sir, scan का film is not.
अरे उमा तुमने बताई थी क्या?
स्कैन की फिल्म नहीं है क्या तुम्हारे पास?
मैम स्कैन का फिल्म नहीं है।
अरे तो लेनी चाहिए थी, तुम्हें केस प्रेजेंट करना था तो। हाँ चलो, रिपोर्ट आपने लिखी है, देखिए रिपोर्ट क्या है?
हाँ मैम।
नहीं तो तुमने डिपार्टमेंट में प्रेजेंटेशन नहीं किया था क्या? अरे इतनी दुनिया देखने लग रही है तो सारा तुमने शोर मचा रखा है एक हफ्ते से, तो इसका सिटी की फिल्म तो होनी चाहिए ना। नाउ द डायग्नोसिस एंड एवरीथिंग स्टेजिंग विल डिपेंड ऑन दिस। चलो गो अहेड।
Other than CT, what else would you like to do for your patient as an investigation?
आप रेडियोलॉजी पहले कराओगे कि बायोप्सी पहले कराओगे?
सर पहले सर सीटी स्कैन करेंगे, उसके बाद सर बायोप्सी।
क्यों?
सर अगर बायोप्सी लेंगे तो टिश्यू वील रिमूव, सो देयर विल बी साइंस ऑफ इन्फ्लेमेशन, और उसमें क्लियर नहीं पता पड़ेगा हमें कि इट इज ग्रोथ और द इन्फ्लेमेशन बिकॉज ऑफ द टिश्यू विच वी डू।
तो अब स्टेजिंग हो
जाए।
तो यू विल डू दैट। तो बताओ क्या फिल्म है, क्या रिपोर्ट तो प्रोजेक्ट कर दो।
सिटी की रिपोर्ट तो है
मैम, रिपोर्ट है वो।
बताओ रिपोर्ट बताओ।
Ma'am, there is a irregular heterogeneously enhancing ulceroproliferative area of 45 into 42 into 29 mm, which is seen in the supraglottic region, involving the right aryepiglottic fold, right arytenoid, and obliterating right piriform sinus, inferiorly extending into the glottic region, involving right true and false vocal cord, contralaterally averting the left false and true vocal cords, with obliteration of laryngeal airway, and also there is a extra laryngeal extension on right and causing cutaneous bulge, superiorly involving the right vallicula and averting lingual surface of epiglottis, posteriorly averting the oropharyngeal wall, multiple centimeter sized heterogeneously and peripherally enhancing necrotic right cervical lymph nodes at level 2, 3 and 4 and 5 are seen, largest measuring 20 into 19 mm at level 4.
रियोलॉजी के बाद आप कुछ नहीं बताओ?
What is the comment on the thyroid which you are saying के स्प्ले हो रही है, टेंडर नहीं है? There is involvement of the thyroid cartilage?
No sir, it is not mentioned sir in the radiology.
But there are certain things in CCT which are different from your findings.
Yes ma'am.
What are those?
Sir, it is involving the right vallicula, and it is averting the lingual surface of the epiglottis, and the contralaterally it is averting the left false and true vocal cords.
अगर वेलिकुला में आ गया है तो प्री एपिग्लॉटिक स्पेस इन्वॉल्व होगी कि नहीं इन्वॉल्व होगी?
Yes sir.
What are the boundaries of pre-epiglottic space?
So pre-epiglottic space is bounded anteriorly by the thyrohyoid membrane and the thyroid cartilage, posteriorly by the suprahyoid.
The thyroid cartilage? The thyroid cartilage anterior?
Sorry ma'am?
The entire thyroid cartilage forms the anterior boundary?
No ma'am, the superior part. forms the boundary.
And hyoid bone?
Superiorly, there is a hyoid bone and the hyoepiglottic ligament. Posteriorly, there is
Roof is by the hyoepiglottic ligament.
yes, sir.
It is a triangular space. Roof of the base is by the hyoepiglottic ligament, and then the thyroid membrane and the lower part of is by the thyroid cartilage, and posteriorly the anterior part of the
Epiglottis, sir.
face of the epiglottis.
But you said there is a subcutaneous bulge in your CCT findings.
Yes, ma'am.
Where was it? Is it at the cricothyroid membrane or it is at thyroid membrane?
Sir, causing sir, cutaneous bulge is seen in the superiorly involving the right vallicula and averting the lingual surface of the
The
epiglottis.
vallicula is not palpable subcutaneously. You said there's a subcutaneous bulge. So where is that subcutaneous bulge?
And you also mentioned some extra laryngeal spread, some word like extra laryngeal spread while mentioning your CT findings.
Yes, ma'am. Ma'am, subcutaneous spread was not there. There is cutaneous bulge was there. And ma'am, in this there is extra laryngeal extension on the right side, which is causing the on the right side and causing the cutaneous bulge superiorly involving the right vallicula.
So it is extralaryngeal extension, na?
Yes, ma'am.
But thyroid cartilage is normal, I think, on CT.
Yes, sir. Thyroid cartilage is normal, sir.
Then how is it going extra laryngeal? But you must have seen the films.
Thyroid cartilage is inverted.
Sorry, sir.
How the thyroid cartilage is inverted by the tumor?
How does this growth
invade the thyroid cartilage?
Sir, through the paraglottic space.
The earlier concept of portal through the anterior commissure, it is no more there in the new Scott Brown. They say the Broyles ligament plugs that gap which is there in the perichondrium. So that is not the portal of entry for the growth to go into the invade the thyroid cartilage. In the new Scott Brown, it has been denied. And how does the pre-epiglottic space get invaded?
So pre-epiglottic space through the fenestrations in the intra-hyoid epiglottis, it can go to the pre-epiglottic space.
They are fenestrations opening, and through that the pre-epiglottic space gets invaded. So your staging T4 is justified or not justified?
now can you say it is T4?
Reconsider the diagnosis.
Now can you say it is T4?
Ma'am, extra laryngeal extension is mentioned in this, so we can say it is a T4A.
And what is T4B? What is T4B?
T4B, ma'am, when the mediastinum get involved and there is encasement of the carotid artery, then it is T4B.
There's one more thing.
mediastinum तो बहुत दूर है. Vertebra का क्या होगा? Vertebra are closer to it than the mediastinum, man. चलो आगे चलो. So you have done the CT radiological investigation. How do you make out what is the investigation of choice to find out whether the thyroid cartilage is involved or not?
Get the question?
Yes, ma'am.
What is the choice of investigation to see thyroid cartilage involvement?
We can go for sir MRI, sir.
What is the finding on thyroid cartilage invasion? Is it sensitive or more specific?
Sir, it is more sensitive.
So chances of false negative are more,
Sir,
false positive.
the chances of true positive is
अरे ज्यादा सेंसिटिव है तो उसको तो कोई भी आ जाए वही पिकअप कर लेगा. And you want to be more specific, na?
yes, sir.
Chalo. Now after radiology, what is the next investigation would you like to do?
Sir, we'll proceed with the sir. We'll go for biopsy of the tissue. We'll go for FNAC of the lymph nodes first, and sir, then we'll proceed with the biopsy of the growth.
How will you do the biopsy?
Ma'am, under general anesthesia, we have to take the biopsy as it is involving glottis and the supraglottis.
Will you able to intubate this patient?
No, sir. Sir, first we have to go for tracheostomy, and then we'll proceed with the biopsy, sir.
So while taking the biopsy, doing the DL, what else will you do apart from taking the biopsy?
So we'll palpate the base of tongue. We'll also examine the group of lymph nodes in the neck.
तो पेशेंट का क्या वैसे देखने नहीं दे रहा था या जीएमआई देखना पड़ रहा है इसमें? Neck तो can be palpated otherwise also.
Yes, sir.
You palpate, see the post-cricoid area there. You said that laryngeal crepitus is missing. Whether do the mapping of the tumor. See all the extent. What is the status post-cricoid apex of piriform fossa? Whether it is crossing the midline. अगर पीछे जा रहे हैं तुम. What is your plan for this patient now?
Sir, surgery. We'll go for surgery, sir, in this patient.
What surgery?
We'll go for total laryngectomy since it is a T4A. Sir.
Laryngectomy alone with something else? Your clinical staging was T4A and 2B.
Yes, ma'am. We'll go for a modified radical neck dissection in this patient.
What are the features of a metastatic neck node on radiology?
Biopsy क्या आएगी इसकी patient की? What is the general biopsy you see generally?
So most commonly squamous cell carcinoma we see.
And what can be the surprise in the biopsy? Apart from squamous cell carcinoma, what else can come?
What are the other possibilities if it is a malignancy other than squamous?
Carcinoma? Is it varicose carcinoma?
No, sir. It can be a conventional, can be varicose squamous cell carcinoma. It can be a.
Does it look like varicose?
No.
हाँ?
No, sir.
Varicose में node आते हैं. Is it very slow growing whitish? Slow growing tumor होता है वो बिल्कुल सालों
Locally invasive होता है वैसे भी.
और उसका जो थिकनिंग और रिपीटेड बायोप्सी करनी पड़ती है, हाइपरकैरोटिसिस और ऑल दैट, आई जस्ट आस्क यू व्हाट कुड बी द अदर और व्हाट कुड बी सरप्राइज इन योर बायोप्सी, और क्या हो सकता है, व्हाट कुड बी द अदर मैलिग्नेंट ट्यूमर व्हिच कैन बी देयर एज अ ग्रोथ इन द लैरिंक्स, दैट वाज द क्वेश्चन.
Sir, clear cell carcinomas.
That means what are the other tissues which can give rise to malignancy in larynx?
It can arise from epithelium, it can arise from mesenchyme. So you can think on those terms and answer your question.
Cartilage is present over here.
99% तो स्क्वामस सेल कार्सिनोमा होता है, 89-90% जितना भी लगा लो फॉर्मलेस स्क्वामस सेल कार्सिनोमा, बट अपार्ट फ्रॉम स्क्वामस सेल कार्सिनोमा दे कैन बी समथिंग as rare as malignant melanoma, chondrosarcoma, adenocystic carcinoma, mucoepidermoid.
There can be minor salivary gland tumors and very rarely lymphomas. And very rarely
lymphoma can be in the supraglottis, but since the both the vocal cords are involved, तो glottis में तो lymphoma कम ही होता है. Even चलो आगे चलो. Your plan is
Total laryngectomy with neck dissection, sir. Modified radical neck dissection.
Can you tell us what is modified radical neck dissection?
Yes, ma'am. In a modified radical neck dissection, lymph nodes level 1 to level 6, the lymph nodes are removed, but we preserve at least one of the following structure, that is either the spinal accessory nerve, internal jugular vein, or the sternocleidomastoid.
So before subjecting this patient to total laryngectomy, would you like to start some counseling or something for your patient, which would help him later on?
Yes, ma'am. We have to counsel the patient since we are planning for total laryngectomy. The patient will not be able to speak after the surgery, and he has to use some prosthesis for the same. So we have to counsel him that he'll not be able to use, he'll not be able to speak post surgery. And
what are the limits after surgery? Total laryngectomy. What all the patient cannot do?
So patient is not will not be able to speak, sir. Patient will not be able to lift heavy weight, and swimming. Patient will not be able to do swimming. He'll not be able to. The olfaction will also go, sir, post surgery.
स्विमिंग के लिए ना एक प्रोसेस आता है जो उसमें ट्यूब में फिट करके, एंड ही कीप्स द ट्यूब हाई अप इन द अबाउट, दे कैन डू टाइटली उसको उस पे ट्रैकियोटॉमी पे फिट करके उसमें, एंड पीपल देयर इज अ पिक्चर इन द स्कॉट ब्राउन, फोर्थ स्कॉट ब्राउन में था. तो लिफ्टिंग ऑफ द वेट, क्योंकि ग्लॉटिस क्लोजर नहीं है, लॉस ऑफ स्पीच, लॉस ऑफ स्मेल, तो फिर कैसे करते हैं? स्मेल के लिए क्या करना चाहिए उसने? ये तो आपका T4 हो गया, मतलब टोटल लैरिंजेक्टमी करती है. आजकल टोटल लैरिंजेक्टमी की क्या इंडिकेशन है? मान लिया ये T1 T2 होता तो तब भी ये लैरिंजेक्टमी करते क्या?
No, sir. Sir, we would prefer radiotherapy or transoral laryngeal surgery, sir. In T1 and T2 cases.
तो टोटल लैरिंजेक्टमी की आजकल क्या इंडिकेशन है?
Sir, when the laryngeal framework is compromised, when the laryngeal framework is compromised, involvement of the cricoid cartilage is there, or arytenoids and the interarytenoids, the arytenoids leading to the involvement, further leading to the involvement of cricoid cartilage.
Is it the commonly involved or the thyroid cartilage which is more commonly involved?
Sorry, sir.
Is it thyroid cartilage which is commonly invaded or the cricoid cartilage more commonly invaded by the tumor?
So the thyroid.
Thyroid. And the most common is post-salvage surgery. You have attempted other chemoradiation and patient has recurrence, and then you go for total laryngectomy. So it is very uncommon to see a patient at such a T4 level. That's why you are going for total laryngectomy. Otherwise, larynx has to be preserved. What is the aim of a laryngeal surgery? Like you have in mastoid surgery, what is the aim of laryngeal surgery?
So,
preservation.
Sir, we will preserve first. We aim at preserving the voice of the quality of voice of the patient, the swallowing,
eradicate the disease, preserve the voice, and preserve the swallowing. तो कौन सा इंसिजन लगाओगे इसके लिए लारिंजेक्टमी कम नेक डिसेक्शन?
Sir, there is a Gluck-Sorensen incision.
What is the other name of it? And what is the modification of Gluck-Sorensen?
Sir, it is a U-shaped.
So what is the other?
Other name is apron flap. वे पूरा एक flap सा उठता ऊपर की तरफ. And modification for neck dissection? What is the modification to carry out the neck dissection?
So it is more U-shaped.
One limb is drawn to the clavicle, other limb is taken to the mastoid tip for carrying out the neck dissection. So that is the modification. And U shape at the tracheostomy site so that the tip doesn't get necrose. Otherwise, the tip becomes, if you make it V shape, that tip will be necrose and more chances of fistula. Then you will clear the level, all the nodes which are cleared, and preserve the.
Sir, we'll preserve the spinal accessory nerve, the internal jugular.
Biopsy was squamous cell carcinoma, well differentiated or poorly differentiated?
So it was a poorly differentiated squamous cell carcinoma.
अगर well differentiated हो, moderately differentiated हो, poorly differentiated हो, तो क्या फर्क पड़ता है?
सर margins जो हम
आपके जो ये node हैं, they are appearance of node is explained by the poorly differentiated. Well differentiated होता है उसमें cells are well differentiated, the lymphatic drainage is less.
Tracheostomy was then done in this patient, है ना?
Yes, ma'am.
Is he operated?
No, sir.
Is the concept of stomal recurrence? Stomal recurrence.
Ma'am, stoma?
Recurrence.
Stomal recurrence. What is stomal recurrence?
Ma'am, at the site of the stroma, there can be due to the seeding, there can be seeding of the tumor, or um, the uh, the tumor is maybe it is left at that site. Mostly, the tumor, the stromal reoccurrence is seen in the when there is a mainly supraglottis uh, in,
Supraglottis
in
or subglottis?
subglottis.
There is a subglottis extension, some mucosal, and which is left behind. And the tumor clearance margin may be positive.
And the classification for stomal recurrence? The Sisson's classification.
During your this thing, when you deliver the specimen and you see the opening of cricopharynx, do something to improve the swallowing, or you facilitate his rehabilitation.
Sorry, sir.
After the delivery of specimen and you have the opening of pharynx, cricopharynx, do you do something there to facilitate his rehabilitation?
Do you do something to cricopharynx?
Ma'am, laryngoplasty, pharyngoplasty.
अरे हेलार ऑपरेशन क्या होता है? पाइलर स्टेनोसिस में हेलार ऑपरेशन क्या होता है?
Have you heard something myotomy?
Yes, ma'am.
एक्लेजिया कार्डिया में क्या करते हैं? अब तो आंसर ही दे दिया, अभी नहीं बोलेगी तो कब बोलेगी? क्रिकोफैरिंजियल मायोटमी, उससे क्या फायदा होता है? जो क्रिकोफैरिंजियल वहां पे प्लेक्सिस होता है उसको काट देते हो तो इट इम्प्रूव द swallowing, deglutition improves and it becomes more patulous, and you put a finger or a thumb in the esophagus and cut the muscles till the esophageal mucosa is seen. समझे? दैट इज क्रिकोफैरिंजियल मायोटमी. उसके दो तरीके होते हैं, लैटरल करते हैं या तीसरा मिड लाइन में भी कर देते हैं. And then you put how to carry out the vocal rehabilitation? What are the ways? Because you said post laryngectomy patient will have loss of speech. How can you restore it?
So we can we can train the patient for the esophageal speech, and so we can use prosthesis like electrolarynx can be used, and
most widely commonly done procedure. ट्रेकियोइसोफेजियल पंक्चर और फिर उसमें प्रोब्स डालते हैं. What is primary, what is secondary? TEP.
What is primary TEP and what is secondary TEP?
What are the indications of post-op RT? Post-op radiation?
Ma'am,
Because clearly your patient will need adjunct. if you are planning for surgery?
पोस्ट ऑप रेडियोथेरेपी कब देते हैं बताओ?
Ma'am, when we are operating in the inaccessible, when the tumor which we have to remove it, if it is present and we are not, it is present the inaccessible site, we go for.
No. After operation, how do we decide that patient needs radiotherapy? You done laryngectomy.
Anything in the post-operative biopsy that you will look for that will.
Ma'am, sir, positive margins अगर होंगे तो we'll go for.
Yes. तो यही सब पूछ रहे हैं, बताओ और क्या क्या फैक्टर्स होते हैं?
Sir, in cases of in case of the residual disease or reoccurrence.
That's positive margin only where you
Positive.
are expecting that you. Yeah. Anything to do with the T staging or the nodal staging that you get in a post-operative HPE?
Ma'am, in T4A stages, we go
T3,
for
T4.
T3.
And then there's lymph nodal positivity. Third, you said positive margins.
अभी तुम्हारा पेशेंट का वुंड नहीं हील हुआ है, व्हाट कुड बी द वेरियस कॉम्प्लिकेशन कैन बी देयर? आज जब भेजोगे ना, जब वुंड पेशेंट ठीक ठाक हो जाएगा, व्हाट कुड बी द वेरियस कॉम्प्लिकेशन दैट कैन अकर? इंट्रॉप आरएनडी किया लेफ्ट साइड में, तो क्या हो सकता है उधर?
Sir, in left side, there can be a chyle leak. Most commonly, chyle leak हो सकता है sir.
तो काइल को कैसे कंट्रोल करोगे? काइल क्या करवाना चाहिए पेशेंट को? क्या करते हैं 1 day प्रायर टू द सर्जरी?
Sorry sir, but
what diet do you give to the patient day before the surgery?
ये काइल लीक का पता चल जाए क्या करते हैं ये?
सर काइल लीक अगर है, सो इफ वी वांट टू सी द, हमें हैवी फैटी डाइट देना है, अगर वी नीड टू कंफर्म इट कि
वो तो पहले दिन देना होता है मैडम। अगर कट गई है वो थोरेसिक डक्ट, तो इंट्रॉप कैसे पता चलेगा?
सर we'll ask the anesthetist for Valsalva and so clear fluid जो में इंट्राऑपरेटिव।
जब रिपेयर करने के बाद करवाते हैं कि रिपेयर हो गया नहीं हो गया वालसलवा, उससे पहले तुमको क्या दिखेगा वहां पे? वालसलवा कराओगे तो और बढ़ जाएगी वो। रिपेयर करके देखते हैं कि भैया अभी प्रेशर बढ़ा के देखो कि कहीं रह तो नहीं गया, लीक हो रहा नहीं हो रहा, तब करवाते हैं वालसलवा। क्लियर फ्लूइड ऑफ द लेफ्ट सुप्राक्लेविकुलर फोसा कीप ऑन इंक्रीजिंग, और वहां पे तुम मॉप करो, फिर वो सोक हो जाता है। फिर देखो तो देन यू लुक क्लोजली, वहां से ऐसे क्लियर फ्लूइड ooze आउट हो रहा होता है। एंड हाउ टू क्लोज इट? एंड इट हैज टू बी रिपेयर्ड इंट्राऑपरेटिवली। अगर है तो यू कांट प्रोसीड फर्दर विदाउट टेकिंग केयर ऑफ इट। अगर तुम्हारा मिस हो गया और फिर नेक्स्ट डे कैसे पता चलेगा कि काइल फिशला बन गया है? आप गए राउंड पे लेने देखने, तो क्या मिलेगा वहां पे आपको?
सर ड्रेन में देयर बी वाइटिश फ्लूइड कलेक्ट होगा ड्रेन में। एंड
कितना फ्लूइड कलेक्ट हो जाता है? नॉर्मली आरएनडी के बाद 70 to 80 सीसी वो सीरोसिग्नस कलेक्शन होती है। यहाँ पे कितना होगा? यहाँ बहुत ज्यादा होगा, 150 के करीब 200 के करीब पहुंच जाएगी। एक्सेसिव अमाउंट ऑफ
Sir, 600 ml per day if it is high output.
and it has to be repaired.
Yes.
इंट्रॉप अगर पता चल गया तो it has to be repaired। अगर पोस्ट ऑफ पता चला तो क्या करोगे?
तो पोस्ट ऑफ पता चला है तो we'll first stop the fatty diet एंड सर डिपेंड अगर वो लो आउटपुट है तो राइल्स ट्यूब के थ्रू फीडिंग कराएंगे और फैटी डाइट को रिड्यूस कर देंगे. In high output, sir, we'll go for surgical repair, sir.
In the low output, what else you do?
What else you will do? वहां पे 2 स्टिच खोल के क्या करोगे?
So your drain should be there. Drain should be there so that you can monitor the kylie. Plus, you need to do pressure dressing. So usually low kylies they get resolved with the pressure dressings only and low fat diet.
और तुम टेट्रासाइक्लिन का पाउडर स्प्रे कर दो, उसमें थोड़ा सा स्टेरोजिंग एजेंट का काम करता है, वो फाइब्रोसिस हो जाएगा. अप्लाई द प्रेशर वहां पे. और तुम्हारा प्राइमरी रिपेयर जो किया है आपने लैरिंक्स का, वहां पे क्या प्रॉब्लम हो सकती है आपके 7वें दिन या 10वें दिन?
Sir, stoma string.
What is the most common complication at 7 to 10 days?
15वें दिन स्टिच निकाल रहे हो तुम, अभी से स्टोमा स्टेनोसिस कहाँ हो गया?
The pharyngeal part, sir, is asking.
जो रिपेयर किया है pharynx, उसमें क्या हो सकता है?
Laryngocutaneous fistula हो सकता है.
Very good. So what are the predisposing factor for the pharyngocutaneous fistula? एक तो आपने बता दिया कि मार्जिन पॉजिटिव हो गया, और तुम्हारे पेशेंट में वेलिकुला तक ग्रोथ आई हुई है, तो he or she is a potential candidate unless you get a remove part of the base of the tongue.
So you can divide them into surgical factors, patient factors, or surgeon's factor. So what are the causes that you can get a pharyngocutaneous fistula?
Can you tell us about patient factors?
Ma'am, there can be low serum albumin, low hemoglobin,
anemia, right?
अगर मान लिया ये सैल्वेज लैरिंजेक्टमी हो तो क्या होगा? क्या हो गया? सैल्वेज लैरिंजेक्टमी है ये, तो क्या हो गया पेशेंट को पहले?
To understand what salvage laryngectomy is?
Yes, ma'am.
What is it?
मान लिया वो सीए ग्लोटिस था पहले, अर्ली स्टेज था, आपने आरटी दे दी, फिर क्या हो गया?
सर आरटी अगर फेलियर होगा देन वी गो फॉर लैरिंजेक्टमी.
आरटी फेलियर हुआ तो आपने टोटल लैरिंजेक्टमी की, सैल्वेज लैरिंजेक्टमी. तो आरटी हुआ, डायबिटीज हुआ, दीज आर द कॉमनेस्ट प्रीडिस्पोजिंग फैक्टर, आरटी एंड डायबिटीज.
So any patient factor which are affecting wound healing, you can include them. Okay. Any intraoperative factors or surgeon
factor क्या हो सकता है? How many laryngectomy have you seen?
Sir.
हैं?
Sir नहीं देखा.
उमा क्या बात है?
The reason be why even we have not seen many laryngectomies in the past few years, but what is the reason why we are not seeing? You can explain it.
Been a lot of research on this, a lot of articles for paradigm shift towards the treatment of laryngeal cancer, towards laryngeal preservation. So that's why
preservation होता है ना, तो कीमो आरटी देते हैं शुरू में, so that voice and swallowing is preserved, so patients are not subjected to total laryngectomy. Earlier T3 used to be the standard treatment कि vocal cord fix हो गई तो laryngectomy कर दो. Now even T3 में give a chemo RT and vocal cord may become mobile and अगर फिर रिकरेंस होती है देन सब्जेक्ट द पेशेंट टू द टोटल लैरिंजेक्टमी, वो सैल्वेज लैरिंजेक्टमी होती है. But how come you are not seen even one laryngectomy? The way you are asking, I could make out. Chalo, anyway. Anything else, Doctor?
Indu ma'am, any questions?
Just the management of pharyngocutaneous fistula, she should know.
Yeah, it can come as a short note. Kyle fistula can come as a short note.
Ma'am, initially we'll stop the oral feed. We'll insert the Rice tube and pressure dressing says, ma'am, usually it closes the pharyngo.
What if it does not?
ये फिस्टुला कहाँ से शुरू होती है और कहाँ निकलती है, कहाँ होता है उसका इनर ओपनिंग एंड वेयर इज द आउटर ओपनिंग?
The outer opening is over the skin and then inner opening is
over the skin. कोई ऐसे थोड़ी ना के लैटरली निकलता है, उसका कुछ साइट होता है मैडम. It is always just above the stoma, either at 11 o'clock position or 1 o'clock position on either side of the trachea. और शुरुआत कहाँ से होती है फिस्टुला की? भाई शुरुआत है वही तो प्रेशर बैंडेज लगाओगे ना, गॉज पीस लगते हैं उसका एक लड्डू सा बना के वहां पे प्रेशर लगाओगे तभी रुकती है वो. तो कहाँ पे लगाओगे? ट्रेकिया पे लगाओगे या टुवर्ड नियर टू द ट्रेकिया लगाओगे या और कहीं पे लगाओगे?
near the trachea.
ट्रेकिया फिस्टुला तो शुरू वहां थोड़ी ना हुई है यार. वहां तो वो एक्सटरलाइज हो रही है, बाहर निकल रही है. तो बाहर वाले को क्या, जहां से उद्गम होता है नदी का वहीं पे रोकनी होती है ना.
So there is a concept of direct and indirect fistula. So in the indirect, you have the internal opening at some other level, and indirect you have both the openings of the fistula at the same level. So what sir is trying to say is, जहाँ पर हम pharynx को repair करते हैं inside, it is near the base of tongue or near the hyoid level. So here we have to give pressure. So the opening is usually here, and the external opening is near stoma.
When you repair the pharynx, either there is a Y-shaped closure or there is a T-shaped closure, and that 3-point junction, it should be re-emphasized with 2-3 layers so that it is totally embedded and covered by this thing. And that is the site where the fistula starts. What is Jackson incision for laryngectomy?
I think it is now the time we are about to finish.
Yes.
So I think she has to read a lot, and this is the suggestion to all the residents that they must read Scott Brown 8th edition. The larynx is given wonderfully in that book. And if you have not seen any laryngectomy that is happening nowadays, so you can go and see the videos on YouTube to get a concept, or you can discuss with your consultants or guides. Okay, so thank you very much, sir. So any final comments, Indu ma'am, Ishwar sir? Then we can conclude.
Yeah, you have to go a long way. You have to improve a lot. Beta, it's so good that you are presented. You have come to know your level and need to read this thing and improve by presenting and seeing the surgery in whatever way you can. You can come to Maulana Azad whenever we can. You can get in touch with the Raman. You can have a word and he can inform whenever we have a laryngectomy. You can visit us. Only that thing we can do.
Chalo. Indu ma'am, any final comments?
She needs to go back and read the textbook. And also there are a number of landmark trials when we talk about treatment of PA larynx. So they've been mentioned in the Scott Brown also, the Veteran Affair trial and RTOG. So residents must know about these two trials at least to know the shift that is there nowadays.
But RDOJ is mentioned 9911. Yeah, 9111.
9111.
Right, sir. So, Uma ma'am, any final comments?
Oh, I agree with both of the external experts that she has to put in a lot and thorough study. She should not be superficial about anything. She should understand and present.
Right.
Okay. So that is all I can.
उमा आपने सिटी का